All right, it is 2:45 Eastern Daylight Time, so welcome back. I know that was a short break, but it was needed after. I'm glad we needed that time, and we needed to hear all of those stories and all the data and all of the information that we had. That was the first part of this meeting, so thank you for accommodating that. I will now turn it over to Lee to run us through the public comment period.
Yes. Hi, folks. Lee Wilson here again. This advisory committee is a public committee, and it falls under the requirements of the Federal Advisory Committee Act, which means this meeting is an open meeting for the public, and we provide an opportunity for public comment, both in writing and verbally. We received one request this time for public comment from Joy Burkhart, who is with 2020 Mom, and we will provide an opportunity for the comment to be provided verbally. If Dr. Burkhart, you are interested in sharing that comment in writing with us, we're happy to receive it. As well, if there are any other people who have logged in and after Ms. Burkhart or Dr. Burkhart are interested in making their presentation, if you're interested, please send a message through the chat to Ms. Kelly, and we will try to provide an opportunity for you to make a comment as well. Dr. Burkhart.
Dr. Burkhart, if you are on, please raise your hand so I can allow you permission to speak.
So while we're waiting, are there any other individuals that would be interested in making a comment to the committee for the record? I'll give about 30 seconds to wait for anyone to identify themselves. Alrighty, Emma, thank you. Absent any public comments, we will move forward with the meeting.
All right, thank you, Lee. Public comment is always important, particularly when we're dealing with issues that we're dealing with today and yesterday. And that's why we're hoping to have at our next meeting, in-person meeting, some really extended period of time, like a full day where we can get comments from community members related to the issues that we're addressing. So now we're going to go into our breakout sessions, the second breakout sessions that we have scheduled. And over the last 2 days, we've heard from 3 particular issues that we hadn't really looked at before, and that was related to the Indian Health Service, the violence, incarceration, murdered and missing women, infants, and women and girls, and then the SID-SUID. So since we had not heard about those before, I would like to have you break up into those 3 groups to see, is there anything that we've learned in the last 2 days that needs to be addressed with those recommendations? Look at the recommendations, and I've broken them up in the draft recommendations by those issues for those 3 groups. So the SIDS and SUID group, Charlene Collier has agreed to moderate that discussion. And the violence, incarceration, and substance abuse, Sherry Alderman has agreed to moderate that one. And the Indian Health Service one, Joy Nahart, has agreed to moderate that. So I want you to look at those set of recommendations, just like you did yesterday. What's missing? What should be prioritized? What additional information we have? Can we collapse some of those things? That's what I would need some feedback from those groups. So You have on your agenda, I think, the link, so I'll turn it over to Emma to make sure that we get into the right groups. And I'm just assuming that, again, like yesterday, they'll break out into pretty evenly matched groups. And then we'll be back in about an hour or so, back at 4 o'clock to report out on those sessions.
Yep, so just like yesterday, please go to our registration website. And then you'll be able to select whichever work group you want to be in. For our panelists at about 3:50, I'll resend you your panelist link to this Zoom webinar. So it should be right at the top of your inbox. For all of our public attendees, once the breakout is finished, please rejoin this main webinar using the link you used this morning. If you have any questions, I'll be remaining in this main room and will be accessible via voice and chat.
It looks like we're all coming back. Emma, will you tell me when all of the work groups have been closed out?
Yep, just was going to say 2 of them are completely closed and the 3rd is wrapping up as we speak.
All right.
Okay, and the final group is wrapping. So everyone should be back in within the next minute or 2.
Very good. Thank you. So we'll hang out just for a second. There we come. They must have had a lot to say in that SID group. That's a good talkers.
We're here.
Thanks, Charlene. All right, I think we're all back. Thank you for your input. I was on one group and there was some good conversation, but it always comes in that, everybody's a little hesitant. What is my role? Do I have standing to talk? Everybody's input is really, really necessary on these calls. So, for the ex officios and the work group members and the SACIMM members by themselves. So we really appreciate everybody's input. And so like yesterday, we're going to just go down from each of the 3 work groups just to find out what you talked about, the input that you have so we can all hear it. And then I'll explain after we're done with all of this conversations, what the next steps in the process. So we'll take them room 1, SUID and SIDS. Charlene.
Okay, thank you. I may need the slides, but I'll try to go through. And I'm Charlene Collier, I'm OBGYN in Jackson, Mississippi, which is the native land of the Choctaw and Natchez and the Ogaspa. I hope I can say that right. People, so I'm happy to be here, very humbled to even lead this conversation and certainly recognizing the importance of this topic. And we had a great conversation. I want to thank Shira Rutman and Sharonda and Tara Sanders and Unique and Danielle and particularly Lee Tanner from a community member and who joined the call. So their contributions are very important. If I'm not looking particularly at my slides, I would say that the recommendations were centering upon acknowledging the need for approaches that acknowledge the environmental, social contributions to the disparities in SUID. We spoke a lot about housing, and particularly acknowledging that housing insecurity and the lack of solutions there drives the disparities in SUID, and then going further to acknowledge how when we speak of disparities, acknowledging where they came from, particularly as it relates to unsafe sleep environments, and that speak of SUID and its disparities as a result of the historical trauma, colonization, racism, it's a downstream effect of those things when it comes to the disproportionate number, particularly of unsafe sleep environment related deaths. And certainly the need to continue to perform research and understand medical conditions that may drive SIDS. We spoke about not reinventing the wheel and looking to solutions that have been done successfully, like the Healthy Native Babies projects, and just bringing more funding and scale to those solutions and to ensure funding for that. We spoke a lot about prenatal care and that many of the risk factors are present in the prenatal period, and we need to provide resources and education to the prenatal providers to address those like housing insecurity or tobacco, and all those things are not just being addressed after a baby is born, and also acknowledging the need for Indigenous midwifery, doula support, breastfeeding. All of those are important. We spoke about acknowledging Native traditions, practices, wisdom, and reclaiming and restoring those as fundamental solutions to infant safety, and acknowledging that all Native and Indigenous people do not live on reservations or have access to their community and that shared wisdom and knowledge, and so find ways and provide funding so that Native communities can share that wisdom. We spoke about cradle boarding and how practices like cradle board classes, talking circles about using them is acknowledged as a infant safety practice, and that there isn't any inconsistencies when there's safe sleep education from either governments or medical providers. We spoke a lot about funding and how it should be going to Native communities and populations to solve the problems that they identify as driving disparities, as opposed to what we see now. Acknowledge when it goes to a medical community, it's often driven from a medical lens, and there should be some source of funding there. So others who want to share or jump in, because I know you emailed me the notes, but I haven't had time to open them. So I'm just going off of my memory, but I think, yes, that those were some of the high points of certainly acknowledging that SUID is a downstream effect of all of these experiences that we've been talking about for the last couple of days, and that infants, when we value Indigenous women and communities and families and provide necessary resources, we'll see improvements across infant mortality results. We spoke also about the potential for creating femurs, particularly owned by within Indigenous and tribal femur programs that use their wisdom and how data is collected and shared. So that's what I remember. If there's anything anyone else would like to add, please.
Just from my perspective, thank you for sharing that. I love some of the issues you brought up. I think we may want to bundle into a sort of an assumption that we just expect these are the things that are assumed to be good best practice without making necessarily a recommendation, but just assume them to be true, good cultural practices. And so I'll look at those in that way. So thank you. Any other questions from anybody to that group?
We also referenced the Broken Promises report and just completing those recommendations, and how that again all ties back into that these are results of those deficiencies has its effect on infant health and safety. So not, again, recreating new recommendations, but completing those as well.
Yeah, that'll be good. Yeah, because we don't want to repeat. If we can say we support the recommendations from, and so that we're at least reference that we know them and they're there, and they put them on record as we're being in support of those, so we don't have to repeat them. It's a good idea. All right. And I know when we go into little groups during the summer, SIDS is not going to be one that's going to be specific. SIDS-SUID is not going to be specific, but it's going to be, I'm going to sort of bundle it with the data and with the clinical care, the care and quality and workforce one. So we'll be able to get at that again. But I just wanted to make sure that after having that session yesterday with SIDS-SUID, we specifically focused on those recommendations today, so we could get an in-depth look at that. All right, so let's go then to the violence, incarceration, and substance use that Sherry Alderman.
Yes.
led.
Yes, yeah, we had a really powerful group. It was such a fabulous diversity of voices and perspectives, and it was everyone really chimed in, and we got into a lot of detail on the 20 recommendations. And I'll stay at a pretty high level to summarize, but I'd like to start with a gap that we found that I think is very valuable, and that is that speaking to data and recommending that there be a survey of what data are available on these topics that we're talking about, data banks, and how coordinated or not they are. And then consider that also when we looked at some of the specific recommendations for specific data to qualify that, we would also recommend that they be well integrated and interfaced with other data collection. So that was a high one for us. We also mentioned multiple times something that was discussed previously, and that is that a glossary of terms, so that we are all understanding what we intend to be communicating when we use certain terms. And speaking of terms, we wanted to be sure that at every point possible, we be very inclusive. And so really assessing the terms that we use and making sure that we are not unintentionally not including certain segments of the population, certain family configurations, those kinds of issues in the terms that we use, so that we are very inclusive. And we talked also about educating professionals, and that it be a very integrated process that is representative of the whole system of care, including bringing, for instance, law enforcement together with medical providers and others to be educated about the issues that we talked about here together. And then one that came up multiple times for sure was that the service array be very comprehensive, starting with promotion and prevention and harm reduction to assessment, evaluation, and treatment and services, and assuring that there's access to all of those components of the system of care. And I open it up to the group members for additional comments.
Any comments from others? I like that, and I know that the data group will be looking at, as we look at this, we'll be looking at the sources of data, and they won't just come from HHS sources. They will come from the Department of Justice and the Department of Housing and Urban Development, and God knows where else they'll come from. But I'm sure that's going to be really an issue, and it's always going to come up with the interoperability and the data privacy and all those things. But that will be part, I'm sure, will be part of our recommendations. Any other questions of this group from anybody else? All right, then let's go to the Indian Health Service with Janelle. Or Joy, I mean, Joy, I'm sorry.
Well, that was probably correct because Janelle did the lion's share of the lifting. So we were fortunate enough to have Dr. Batara join us and give us the guidance she was able to, which was really helpful. So basically we took, looking at the 6 recommendations in the draft, reworking, prioritizing that funding needs to be not dependent each year on changes, but baked in and reliable. We talked about a lot of other things that I'm totally blanking now, but I would love if Janelle would jump in.
Sure, I'm happy to help. And I also took notes, so I'm cheating too, Joy, okay? The overwhelming bit is that for as little as our audience thinks they know about Indian Health Service, you know far more than the average person walking down the street.
Absolutely.
Just know that you are an honorary inductee into an Indian Health Service professional background understanding, okay, even though that's very little. And that is for me as well. Like, I do not have a comprehensive understanding of Indian Health Service. So we had a good portion of our discussion pertain to just the funding issue and the mechanism. So the overall big priority goal, which is something that we echo from our last set of recommendations last year, was to just fully fund Indian Health Service and make it, make it continued funding, something that is not cut. No funding is sequestered, and looking to models as to what the standard should be, not just meeting the bare minimum, but even more. And then following that, we then had a discussion about certain priorities under the funding. Would it fund, comprehensive data collection and what that would look like? Would it fund workforce development and recruiting, retaining, and integrating community members into service within Indian Health Service? We also then talked about having a body within HRSA that would be like the Native American, Indian, Alaskan Native kind of point body that would be able to integrate all the work that HRSA is doing, in addition to what IHS is doing in terms of their maternal, child, and infant health work. So we have so many hands involved doing different things and measures, but there really is no centralized office that knows what everyone is doing, and that might be helpful. We talked about, let's see, when it comes to data collection, just supporting efforts to allow comprehensive data collection, whether it's within HRSA, with CDC, with the Indian Health Service, within tribal epidemiology centers, with tribal communities, but just finding methods to really allow comprehensive data collection, because we don't have that. It's fragmented. And we have small population numbers and tribal identities as reasons as to why we don't have this, and also funding, lack of funding, that's a big one. So I think then we also talked a little bit about involving the community in almost every step of the way, basically. So whether it's workforce development or if it's evaluating if Indian Health Service is meeting their actual needs, but community voices and representation and integration is needed, in addition to identifying ways to support traditional healers and practices for reimbursement. Mm-hmm. And finally, we discussed a little bit about Indian Health Service and the Acog contract, their just relationship, just having a little bit more background understanding of that. We still don't have much information, and it would be really helpful to understand over the past 50 years what activities have been done, what are the outcomes, have they been measured, and if this relationship is evaluated anyway. And we understand that Indian Health Service has similar contracts with other entities related to healthcare. So it's not just ACOG, they have other contracts with pediatrics and possibly injury prevention or mental health. So there's other contracts as well. It's not just maternal child initiatives, but this is one that we are interested in understanding. Are there any questions?
All right, thank you. It looks like Lee has his hand up.
Janelle, thank you. This is Lee. I'm just wondering if you can expound a little bit on what you mean by fully fund the Indian Health Service, because this comment has been repeated a number of times as a recommendation, and it's a very broad recommendation. So I'm just trying to get a sense of what that means.
Sure, thank you, Lee. Anytime I get a chance to talk. So a number of reports, GAO reports, have commented that IHS has not been adequately funded. But in addition to this, there is a report, and I have to find it. I'm not sure if it's Broken Promises, but there is a report, and I'm going to butcher the name, but there's it's the funding portion of maybe like tribal, tribal budget opportunity or something. Every year, I understand there is an entity, and I'm not sure who it's connected with, because whether it's National Indian Health Board or some other national Native American organization, but there are actual people who come together that evaluate the current needs for this fiscal year and next fiscal year that Indian Health Service should need, what tribal communities would need. And I believe that where we are sharing, where we're all citing each other is probably from this tribal arm of organizations and people that have come together that have really evaluated the funding. So
I think it would be useful to consider how you reference that, just given my experience working with some of the budget issues associated with the Indian Health Service. I don't want to make recommendations for the committee or direct you in a particular way. However, the Indian Health Services not only funds services, but has an enormous construction budget and maintenance budget attached with the hospitals and sewage and all sorts of things, water supply. And there are assumptions that are baked into what the ongoing costs are. And there are, lifespans of various activities. And some of those assumptions are very, very underfunded as well. And so what might be seen as fully funding would be based on projections that a group like this may or may not agree with. So I think it's a broad issue. And I think if you were to consider specific areas that you are keenly speaking to, it would go a long way in sort of explaining this as our committee say these pieces cannot be sacrificed. So that's my recommendation.
So this is one of my takes. Some of the comparison: we spend $13,000 per person per year on medical care, and for the American Indians, it's probably about $4,000. We spend so much on public health activities per person per year. Doesn't get related to a similar level on tribal communities. I think we need to start making those kinds of comparisons when we say what's the adequate level of funding.
Okay.
Yeah,
Right.
we will include that from especially the 2017 and only most recently the 2020 funding, the 2020 funding that came out for IHS in general included that bump because of COVID. Otherwise, that would not have included a bump that brought them up to where it hadn't been anticipated was needed.
I love this. In fact, we got lots of hands up on this one, so this is good. So we'll start with Joy.
No, I'm just wondering what if we could get, like, where do we get the data on how much Medicaid spends per patient per year and Medicare, and then what's the base funding for that's provided to Alaska tribal health systems versus base funding per person for Indian Health Service, and give those comparisons when we making the case that IHS continues to be historically underfunded.
So this raises a good point. Of the 4 little work groups that we're going to be having, I think the one that's going to need the most, that will be doing the most work in terms of amount of time spent, is going to be the one on Indian Health Service. And that has not gotten any volunteers. So it'll be Janelle and me working on this. But we would love to have somebody, because there's going to be some work that needs to be done in the Indian Health Service, because there's so much ground that we have to cover. I think the other work groups are going to be pretty straightforward, and you'll be able to do that work pretty quickly. So if anybody really has an interest to dig into this deeply, please let me know. I'd love to add you to that work group, because we're going to have to be doing a lot of work over the next month or so. And I think with Dr. Patara, we've got a partner to help work through some of that. So let me know. All right.
I will change groups.
Oh, go ahead. Okay, Joy.
I will change groups and continue to work with Janelle and you on this.
Okay, that would be helpful. Thank you. Jean.
I just wanted to speak because I think when we're talking about a contract and all the work that Acog has put into the Indian Health Service, it's a very robust program with very dedicated physicians and leaders within Acog. I would never be in a position to suggest the intricacies of the contract or how they engage, who they do and what they do. But I think if you're planning on any discussions, I would bring in the Acog leadership to do a presentation or to be part of this. And I'm not volunteering because I'm history.
No, we got that message loud and clear earlier on. We need to have all of the voices at the table. Magda.
Yeah, I just want to acknowledge that Dr. Lau let us know about, and Jeannie, you know this, in the Green Journal of OBGYN in 2020, there was a significant article that summarized the 50 years. And I don't know if that made it into our briefing book or not, but I think that that's, I did not know about that. And so Tina was able to share with us, and she's sending us the link to that. So there's not a formal evaluation, but there was a Green Journal publication. So Karen, thank you for sending that article to Janelle just now. We really appreciate that. That was one clarification. And the second clarification, and I'm happy to just end with this piece, is that I think we talked about trying to figure out not only to say adequate, you have to find what that is, fund, what do we mean by fund, Indian Health Service, but we also want to talk about the mechanism. And I think that was the thing we heard consistently over the last 2 days, which is this notion of mandatory funding to fulfill treaty obligations that were made. And not be at the mercy of appropriations. And so that the mechanism of funding, not just the level of funding. So I think as we deconstruct adequacy, it should be about continuity and not just and sufficiency. And so I just want to make sure that that was elevated up in our report.
All right, thank you. Yeah, I heard that loud and clear multiple times. All right, any other questions for the Indian Health Service group?
Just a thanks to Joy for doing her first ever moderation. So she's learning, and for Janelle to budding with her. Really appreciated the leadership of this group.
Thank you, Janelle and Magda.
All right. Well, so what I'm gonna do with this, following this meeting, I will take the feedback from all of these breakout sessions, and I hope that the moderators of those 6 sessions could get me something by early next week. I mean, it doesn't have to be in great detail, but just whatever you can get me by early next week. And then I will work and redraft those recommendations. And then I'll send them back to the 4 task groups for one more review. This is going to be your last chance, one more time to really review them. And you can review them in any way you want. You can get together as a group and really discuss them, or you can kind of get individual feedback, but trying to get them this last draft before we make it available. And remember, reminder that it's one related to the Indian Health Service, one related to data, and Magda wanted to make me sure that storytelling is going to be part of that. The violence, incarceration, substance abuse, care delivery, and workforce. And so, like I said, I would then like to have you do that and have your comments from that next level of review back to me by Friday, July 22nd. And then I will then do another draft, and then send it out to outside reviewers. And this is where I would like to also, any suggestions that you have about who we should send this to prior to our September meeting, so that, and to get some feedback from people who, you know, could give us some helpful. And then with their feedback from that group, I will try to get a final draft ready for our September meeting, which is going to be, I hope, in the Shakopee, Midwakot, and Sioux community here in Shakopee, Minnesota, between 3 and 4 miles from the Shakopee Women's Prison, on September 13th, 14th, and 15th, with a travel day on the 12th. And at that meeting, I hope to have one day of testimony where we bring in as many voices as we can, both in person and virtually. Again, any recommendations you have about who should be making statements in response to our recommendations, but also bringing up other issues that we may not have addressed. Would also like to have policymakers engaged in this as much as we can. We will be inviting the Secretary of Health and Human Services. We'll be inviting the Secretary of the Department of Interior. I know the HRSA administrator would love to be there, and I hope that she can. I will be inviting our governor and our lieutenant governor here, who's an American Indian woman who I think might be able to attend for sure, and certainly our senators. But trying to get this is an opportunity to really get this out as an important issue in front of the policymakers. And then also at that meeting, then we will finalize our recommendations, and then we'll also then have transition of our membership, our one group going off and the others taking full leadership of that. So that's what we're going to be doing. That's sort of the next step. So any questions or comments about that process?
Sounds clear, Ed, and thank you for leading the charge here and keeping us on track. Really appreciate that.
All right.
And I hate to be the calendar clarifier, but it's important, I think, especially for the active clinicians. We've saved 13th and 14th for meeting dates and travel on the 12th. Are we going to meet also on the 15th now? So extend it to the 15th? Yes,
the Thursday. We're going to meet Tuesday, Wednesday, and Thursday. Travel on Monday, meet on Tuesday, which is going to be basically a testimony day. And then Wednesday and Thursday will be our full committee meeting like we've done here over the last 2 days.
Okay.
And that's parallel to what we were going to do now, right? And it's similar.
That's what we initially had planned for June, but then we moved it, sort of just picked it up and moved it to September. All right. There's a lot of conversation we could have, a lot more things that need to be discussed. So let's take about 15 minutes. I'm not going to go around the circle and ask for each individual person, but I would like to get some thoughts that people have of what you've learned in brief form, please, so that we don't go until 6 o'clock Eastern Daylight Time. Just some thoughts about the meeting. What did you learn? What new? What's still missing? What do we have to do? Charlene?
I just wanted to share how humbled and really almost embarrassed I am by how little I've known about the experiences and conditions of Native Americans and Indigenous people as an OBGYN. And we have coupled maternal morbidity, mortality, and saying there are elevated rates in Black and Indigenous people, and I have a very clear picture of Black maternal mortality disparities because that's the community I serve and that I've been a part of, but I have not known, and I still have yet to interact with the community and the population, or really done my due diligence in seeking out those voices. And after all of this, I still am very, hungry for more of just hearing directly from this community and population, and hope that we can find ways to elevate those stories. So the photo voice, the documentaries, I think we need much more of that, where we can feel that connection, because I still feel very disconnected. It's all things being told to me, and I think the space, as we mentioned, kind of like if there's a hear her, there needs to be a specific space around Indigenous hear her, Indigenous populations and communities, and I want to hear more directly, and I think many, as a State Department of Health, just want to do more to reach out and engage, and so I think I was sad by how much was brand new information to me, and there's a lot of work we have to do to bring these stories to light. So thank you for all of those, particularly those of you who have shared, and this is from your personal experience and your lived experience. So I appreciate it.
And I want to call out, and I raise Lee Wilson. I want to thank you, Lee, for being so supportive of us having our meeting on tribal land. This committee has never met outside of Rockville that I'm aware of, and certainly never met on tribal land. And Lee's been very supportive of us doing that. So this is going to be a unique experience. And I hope it's one, Charlene, that actually allows you to learn a little bit more. That's why I really hope that all of you members can come and be on tribal land and hear directly from individuals who are affected by our society in various ways. So thanks. Steve.
Thanks. I was just going to add that yesterday, all throughout the meeting, I've been really impressed by meeting the new members who have joined us. And particularly yesterday, Sharonda Thompson, I think, really summarized it for us in the equality and access discussion, where she said, this is a committee that's focusing on, infant and maternal mortality. She said we also shouldn't forget that we should be focusing on maternal and infant vitality. And it just stuck with me overnight and through the day today. So, Sharonda, thanks for that. And thanks for being part of the committee, as well as all the rest of the new people who I'm enjoying getting to know.
Yeah, I'm comfortable with what's going to happen once I leave this committee. Well, again, I don't have much. Yeah, it's going to be a good group moving us forward, without a doubt. Other comments or reflections on the meeting? Jeannie.
Yeah, I just wanted to say and echo what you had said, that with Janelle Palacios bringing this forward and opening everybody's eyes in a very eloquent and very powerful way, I think it's helped everybody. I just think the meetings have really developed very strongly, and I like very much appreciate, Ed, how you've conducted everything, and then allowing people to be a spokesperson and advocate and show their passion, but then bring in all of the different committees to provide that information, I think has been a really wonderful element of the committees. And I too I won't be here with all of you, but look forward to the new committee members who are going to be taking over and contributing so well.
Well, and Jeannie, I do hope you take time to review and stay engaged with our committee, because it's a public meeting, and I will send you some information. So any feedback you get will always be welcome.
Thank you.
Magda.
Well, I want to acknowledge just how much work went into making this meeting happen. And I just think that it's because we don't just show up, but that there's a lot of work that each person has done to make today possible. And it will only happen if we take it more than just showing up for a meeting. So kudos to everyone who prepared and set the stage and set the agenda and created the political will. So first, a thanks for all the things that happened beforehand, because if it comes off seamlessly, it's because of that investment up front. And that gives me hope that we'll be able to sustain that investment right through to delivering a potent set of recommendations that will get off the shelf and into action to make a measurable difference. So kudos for that. The second that I want to do is just acknowledge the joy I felt from the new members as well as our presenters who welcome strategic storytelling. You know, as a data maven my whole life and as a scientist, and many know that I've shifted into this world of elevating the power of story, the capacity of story, the readiness for story, the strategy of story as being a missing component in our work. And I said up front that, what will it take to shape and drive more powerful narratives, not just based on sound science, but lived experience. And so to the new members who 201 said, what about the story and story, our data, and our speakers as well. Oh, I feel like I have a whole lot more company and I'm not out on a limb on that one. It's not soft science. It's the heart and head of the matter that need to go together. And last, I also said in my what will it take is this notion of collaborative, courageous leadership, which will give us the wisdom to make difficult decisions based on incomplete or imperfect data. And so my observation over the last 2 days is that we have the capacity to collaborate in ACIMM, ACIMM, whatever an acronym you want to use. But the reality is it's the persistent and persevering courage, because it's structural while we have never been on Indian land. It's structural while this has been insignificant numbers and not talked about, while it's been an initial without a whole lot of depth. And we get to elevate up Indigenous health and First Nations in a way that is long past due, and it should never be an asterisk as insignificant ever again. We change the rules of how maternal and child health will work. And that to me gives me high hope. What I hope won't happen, and I don't think we will let it happen because of our courageous leadership, is that this will become a topic that says, oh, we covered that, let's move on. May the social DNA of ACIMM, ACIMM be altered because of the work we are doing, never to regress again into the margin. It's a delight and an honor to be here. Thanks so much.
All right, thank you. Janelle.
Thank you, Ed. This is just, I'm going to try to be very quick, but I want to just let you know that I'm very grateful to you since the very beginning of this first committee meeting, when it was restarted almost 4 years ago, that you shared that you wanted people to be brave and courageous, and you wanted us to tackle issues that needed tackling. And you gave us space to be able to be authentic and space for us to really work for the changes that we felt or we see we needed. In particular, I want to also thank the committee at large for letting us veer off into Indigenous health concerns. And I know that we've spent a few meetings on this topic. And I want you to know that as I'm departing from the committee after September, it's all in your hands. What happens, what actions are taken later. So I'm here at your service to offer you any thoughts, or if you want to discuss anything a little bit more deeply. I also want to just point you to September 21. We had an ACIMM meeting, and on day 2, I gave a brief presentation on Indigenous history and related to maternal child health outcomes, and I included the lived experience of my family in that. It's recorded, you're welcome to review it, but that also serves as a great foundation for understanding how history has affected policies today that affect Indigenous health. Lastly, I want to just end with centering us back to humanity and recognizing that we need to work as a community to improve life, not just for Native women and infants and children or women in general, but for the whole community, for fathers, for grandparents, for everyone, because that's really the work that we're trying to do. Many may not know this. You might be familiar with Centering Pregnancy. It's a group prenatal care model that has been shown to do a number of positive things for pregnant people and postpartum people. It helps them with self-advocacy and health literacy. It helps them be, have less stress. It helps them have better maternal infant outcomes. But did you know that Sharon Schindler Rising, the nurse midwife who created this program, this model of care, modeled it after a Native American talking circle. So we are bringing Indigenous ways, not just Native American ways, but Indigenous ways of knowing, whether that's in Asia or Africa or in the United States. We're bringing Indigenous ways of knowing into our daily lived experience and health. So I would continue to advocate for us to look for those places where we can bring that into our lives, into our research, because I think they had something with a talking circle. I think there's something to be said about Maslow's hierarchy, that he had it wrong, perhaps, and it was upside down, right? So what else have we not listened to appropriately, but we have space to do that here. So thank you.
Thank you, Janelle. Thank you for leadership on this. And certainly our efforts looking at Indigenous health has not been a veering one direction or another. It is central. It is core to what we have to do. It would have been, like I say, public health malpractice not to focus on the needs of American Indians and Alaska Natives. Because as Charlene pointed out, we've ignored this group for so long. Just because their numbers are so small, that doesn't mean they are not absolutely essential and core to what we need to do. And as I tried to point out at the beginning, that this is going to impact the health of everybody in this country, that what we come up with. And so it is essential that we do this. So thank you for your leadership on this, and look forward to more of that as we move ahead. Any other comments? Any comments from the new folks that have just recently come on? Would appreciate any kind of thoughts that you might have.
I have my hand up.
Oh, go ahead.
It blends in, I suppose. So I want to thank everyone for having me be part of this committee. I feel like a small one among giants, but I'm learning. I guess I'm just realized that Janelle is terming off, and so I hope I can live up to her standard, and I hope that she'll let me continue to be she'll continue to be a resource for me. And the comments that Magna made about stories are what brought me to the 2-year process of this being appointed to this committee. The stories of the moms and the children that I've cared for over the past 20 years, and the good, the bad, and the ugly, but those stories drove me to want to do better for all moms and kids across the country. And again, I mentioned several times that I'm just recently a part of a tribal health organization as a pediatrician, and I feel like these two things coming together at once, this committee and this job, I working together, I think I can do lots of good things, not just for kids in Alaska, but for kids all over. So thank you for having me.
Thank you, Joy.
Great.
All right. Well, it's been a busy couple of days, and it's really been nice. I've really bonded with this group of ACIMM members, even though I've only met with them in person once. And I know they got together twice, but I just bonded with them even just in person once, but I've really bonded. These are now my lifelong friends and colleagues. And I'm also, really pleased with the expertise and involvement of all of the new members. So I really feel good about where the direction that ACIMM is going to go once we transition off. Lee, you had a comment?
Yeah, I do. I just have a few items that I wanted to mention as we close out this meeting, if this is a good time to do it.
Yeah, this would be good. And then I'll have a closing last comment like I usually do.
So first, as a federal representative and as the acting DFO on this, I'm humbled at the opportunity to be able to participate in an event like this with a group of individuals, with the members that are on the committee. In particular, I want to just give my thanks and appreciation both professionally and personally for the opportunity to work with Jeannie Connery and to work with Paul Wise, two very, very bright lights in this area. And just the insights that I've been able to glean from the conversations that we've had, both in a group and one-on-one, have just been invaluable to me and something that I will remember for a very, very long time. So thank you for your hard work and for your openness to engage with me and with us. It's been a remarkable journey, and one that I hope we get to continue through different paths over coming years. Also, thank you in advance to the committee members who have agreed to extend their terms for the remainder of the year to get us through the discussions that we're going to be having in September around tribal health and the recommendations that you will be making in that space. We are planning to meet in Minnesota in September, as Ed had given the dates on that Tuesday, Wednesday, and Thursday. Please be on the lookout for information from Michelle Lowe on our staff, who will be making the travel arrangements for all of you in making all of this happen. We are set for that meeting, and I've said that before, and then COVID and other issues have jumped into place. Hopefully that will not happen. We have a great deal of support here, and transitioning on this topic. And I think we've made some real good bridges with the new people who are at the Indian Health Services. I want to thank them, even though they're not here, but I'm extending some thanks in writing to Dr. Christensen, to Dr. Patera Lau, and to Ms. Carr for their willingness to step in, given the very, very busy workloads that they have at IHS. Not that we don't have all have busy workloads, but they did put forth a great deal of effort for this committee. And I hope to continue that relationship. In fact, it's already paid off because we're in negotiations, discussions about information regarding formula and whether or not we can help them out with making some connections that we have in that space. So I appreciate that, and I appreciate all of your flexibility when it comes to adjusting to meetings being on again, off again, virtual and in person. It is a difficult juggling process for us right now. And I do want to call out again Ann Leach, Michelle Lowe, Abigail, Judy Deschatley, for their participation in their work in making this committee meeting go. Finally, and as well as the Emma and the LRG team. Finally, I do want to just recognize all of you, and in particular, Dr. Ellinger, for his dedicated and tireless and persistent work in this space. He does not let anything go, and you get very full, rich meetings because he is so persistent and deliberate in his thinking on these activities. So thank you all. I will turn the closing remarks over to Dr. Ellinger, but if you have any questions, concerns, comments, or feedback, please do send them to me directly at lwilson@hrsa.gov. And we will be turning over the DFO role after this meeting back to Vanessa Lee, who handles it so much better than I do. So thank you all.
Thank you, Lee, for all your work.
Thanks, Lee.
It's been a real pleasure working with you. So let me leave you all with this. Today is Magna Carta Day, which you probably didn't recognize. On June 15th, 1215, King John signed the Magna Carta at Runnymede. Now, the design and concept of the Magna Carta led to the Declaration of Independence, the United States Constitution, the Bill of Rights, and many of the states' constitutions. They relied on the Magna Carta for guidance. But the reality was, back in 1215, that document was really very limited to a very specific thing. But it stimulated the imaginations of others that followed. That was the power of the Magna Carta. As limited as it was at the beginning, it stimulated the imagination of the people that followed. And it ultimately formed the foundation of democratic values and principles. So our document that will be coming may or may not be limited, but I hope it stimulates people's imagination about what could happen and stimulate the action that needs to happen to make that vision come true. So on Magna Carta Day, go out and change the world, because we're on our process of doing this. So thanks for all your work. Thanks for your involvement. And I will get stuff back to you as soon as I can after I get input from the work group. So enjoy the rest of the day and the rest of the week, and peace to all of you. Goodbye.
Thanks, Ed.